Okay, think about this for a second. You walk inside from the bright sun, right? And your eyes adjust. Pupils get bigger. We barely notice it.
It's automatic.
But what if?
Hmm.
What if that didn't happen quite right? Like one eye's pupil just wasn't keeping up.
Now you're leading us into a really interesting and clinically vital area, especially if you're revising for the MSRA.
Exactly.
We're going deep today into something called the relative afferent pupillary defect. You'll also hear it called RAPD, or sometimes Marcus Gunn pupil.
RAPD or Marcus Gunn. Got it.
And our mission here, really, is to give you a solid, clear handle on RAPD. We're going to cover, the definition, causes, management, the whole picture.
So basically a shortcut to getting properly clued up on this for the exams.
That's the plan. And look, RAPD is so important because it can be an early warning sign, sometimes showing up before other symptoms even surface.
Okay, right. Let's start simple then. What is it? What are we actually looking at when we talk about an RAPD?
Okay, so boiled down, RAPD means the pupils aren't responding normally, or rather symmetrically, to light. When you shine a light in the affected eye, you see less constriction, or sometimes it even looks like both pupils slightly dilate compared to when you shine a light in the other, the healthy eye.
Ah, so the key is that word relative. It's the comparison.
Precisely. It's not that the pupil is completely dead to light that suggests something else entirely. It's just weaker or maybe slower compared to its partner.
And it's also called Marcus Gunn pupil.
That's right, yeah. You might see either term pop up.
Okay, so this difference, this imbalance in reaction, that's the real signal.
Exactly right. That difference is telling us something's up with how the light signals are getting processed between the two eyes.
So that naturally leads to
Why?
why? What causes this kind of imbalance? What's the usual story, the etiology?
Well, our sources really point towards the most frequent cause being a problem with the optic nerve, but just on one side. A unilateral optic nerve lesion.
Okay, unilateral optic nerve, like what sort of things?
Classic examples would be optic neuritis inflammation of the nerve, or maybe the nerve is being compressed by something, or even ischemia, reduced blood flow to the nerve.
Right, that makes sense.
Yeah.
The optic nerve is the main cable carrying the visual info, including those pupil signals.
It absolutely is. So, yeah, significant damage to that cable on one side. That's a prime suspect for causing this unequal response.
But it's not only optic nerve problems, is it? I think our sources mentioned other things too.
No, you're right. It's broader than that. Certain diseases affecting the retina can do it as well, especially if you're talking about, say, a really severe retinal detachment.
Okay.
Ocular trauma is another one. And then, yeah, there's quite a detailed list if we want to be really thorough for a revision.
It does seem comprehensive. Maybe worth touching on the main groups.
Yeah, let's do that. So we've got various optic neuropathies, arteritic, non-arteritic. Interestingly, even quite mild optic neuritis can cause an RAPD.
Huh, even mild cases.
Yep. Severe glaucoma is another, especially if one eye's nerve is much worse off than the other. Then there's traumatic optic neuropathy injuries to the eye, orbit, even the head.
Okay.
Rarer things like optic nerve tumors, orbital diseases that might squash or affect the nerve. Think thyroid eye disease, for example. Or vascular malformations.
Yeah.
Optic atrophy, like in Leber's optic atrophy. Infections or inflammations affecting the nerve, cryptococcus, sarcoidosis, Lyme disease. You get the picture.
It's a lot.
It is. And then shifting more to the retina, severe ischemic conditions like vein or artery occlusions, sickle cell retinopathy, retinal detachment, particularly if the macula is involved.
Macula involved, right?
Very severe unilateral macular degeneration. Certain retinal infections like CMV or herpes simplex. And even in really severe cases, amblyopia, a lazy eye.
Okay, that is a genuinely broad list for, practical revision, MSRA focus. Are there maybe 2 or 3 big categories we should nail down first?
Good thinking. Yeah, I definitely say focus on optic nerve issues. First, optic neuritis, compression, then severe retinal problems, detachments, major vascular occlusions.
Okay.
And maybe keep trauma in mind as a distinct category too, eye or orbital injury.
Optic nerve, severe retina, trauma. That helps narrow it down initially. So thinking about all those causes, does that mean certain people are more likely to develop an RAPD? Any specific risk factors?
Yeah, the information suggests a few things. Definitely, if someone has a known history of optic nerve disease, that puts them at higher risk.
Makes sense.
Also, having had eye surgery or experiencing significant eye trauma, and then more generally, just having any condition known to affect either the optic nerve or the retina, it tracks logically from the causes, doesn't it?
It does, yeah. Okay, so we've got the what and the why. Let's get into the how. What's actually happening physiologically, the pathophysiology behind this difference in pupil response.
So fundamentally, RAPD comes down to an imbalance in visual input between the eyes. That's the core concept.
An imbalance. Okay.
Because of whatever issue is affecting one eye or its nerve, that eye just isn't sending as strong a light signal back to the brain compared to the healthy eye.
Right.
And it's this impaired signal transmission, as the sources put it, that results in the reduced pupillary response we actually see.
So one eye's message is weaker.
Yeah.
How does that play out with the pupils then?
Okay, so think about the pupillary light reflex pathway. Very briefly, there's the in pathway, the afferent limb, that starts at the retina, signal goes along the optic nerve, passes through relay station, the lateral geniculate body, then hits the midbrain where the reflex control center is.
Okay, the afferent in pathway.
Then there's the out pathway, the efferent limb. That starts in the midbrain, in the Edinger-Westphal nucleus, sends signals out via the oculomotor nerve to the iris muscles, telling the pupil to constrict.
Got it. In and out.
Now, in RAPD, the problem is somewhere along that afferent in pathway. Crucially, it's before the point where some nerve fibers cross over the optic chiasm.
Before the crossover.
Exactly. Because it's before the chiasm, the defect is specific to the signal coming from that one affected eye. That's why the response is different depending on which eye you shine the light into.
That really clarifies the relative part again. So if we spot this RAPD sign, what else might look similar? What are the differential diagnoses we need to keep in mind?
Good question. When you see that asymmetry, you do need to think broader for a second. Sometimes very severe retinal disease in one eye could potentially mimic it.
Okay.
Obviously, the optic nerve lesions we discussed are top of the list. You might also briefly consider if a very dense cataract in one eye could affect the light input, though typically cataracts don't cause a true RAPD. And finally, you need to rule out any physical problem with the iris itself, like posterior synechiae, adhesions, or maybe previous trauma. Anything stopping it from moving properly.
Makes sense. Rule out the mechanical issues and other severe sight problems. Now, how often do we actually see RAPD? Is it common? What's the epidemiology?
Well, interestingly, the sources say there isn't really specific data for RAPD itself. Its frequency really just mirrors how common the underlying causes are. So, in a population where optic neuritis is more common, you'll likely see more RAPD linked to that. If severe glaucoma is prevalent, you'll see more RAPD from that cause.
Got it. It's a sign, so its prevalence follows the diseases it signals. So how does it actually present? What are the key clinical features we look for?
The absolute key feature, as we've touched on, is that relative pupillary dilation or lack of constriction in the affected eye when you compare the light response to the normal eye.
And the test for that is?
The SwingingFlashlight test. It's non-negotiable, really, for detecting RAPD. It's part of any good pupillary exam.
Right.
And the finding you're looking for is this. When you swing the light quickly from the good eye to the bad eye, both pupils seem to get bigger, or they constrict much less strongly than they did when the light hit the good eye.
That SwingingFlashlight test sounds absolutely crucial then.
It really is.
So let's say we do that test and we suspect an RAPD. What investigations follow? What's the workup?
Okay, first step is always a really thorough, comprehensive ophthalmic examination. That means checking visual acuity carefully, doing that detailed pupillary exam focusing on the swinging light test, looking at the back of the eye with fundoscopy, checking the retina and optic disc, and visual field testing is important too.
Right, the full eye MOT.
Pretty much. And then, depending on what you find there, you might need additional investigations. Often that means imaging.
Like MRI.
Exactly, MRI or maybe CT scans. These give you detailed pictures of the optic nerve, the orbit, the brain, helping you pinpoint that underlying cause we keep talking about.
Right, so finding the cause is key, which leads us to management. If we find an RAPD, how do we treat it?
Well, the crucial thing to grasp about managing RAPD is that you don't treat the RAPD itself, you treat the cause. The focus is entirely on treating the underlying condition.
Okay, so give me an example.
Sure. If it's optic neuritis causing the RAPD, treatment might involve, say, corticosteroids or maybe other immunomodulatory drugs.
Right.
If the cause is the optic nerve getting squashed, maybe by a tumor, then surgery to relieve that pressure could be the answer.
And if it's retinal detachment?
Then surgery again, but this time to reattach the retina. It always comes back to fixing the root problem.
Makes sense. Treat the disease, not just the sign. What about the outlook? If someone has an RAPD, what's the prognosis generally like?
It's really variable, honestly. It Completely depends on the underlying condition.
Okay.
If the cause is something reversible and it gets diagnosed and treated quickly, then yeah, the RAPD might improve, potentially even disappear altogether.
Good news.
But if the damage to the optic nerve or retina is severe and permanent, irreversible, then the RAPD is likely to stick around. And unfortunately, that often goes hand in hand with some permanent visual loss.
Right. And are there complications we need to worry about, either from the RAPD or the things causing it?
Yeah, the sources are clear that complications are primarily related to the underlying cause.
As expected.
The real worry is if that underlying condition isn't treated. That can lead to progressive vision loss, permanent optic nerve damage, optic atrophy, and just general complications from having a dysfunctional optic nerve or retina.
So timely diagnosis is vital.
Absolutely. Timely diagnosis and appropriate management are crucial, as the notes say, to help prevent or minimize these potential complications.
This has been incredibly helpful. A really solid run-through for revision. Any memory aids, mnemonics maybe, to help all this stick for the MSRA?
Definitely. Okay, for common causes, how about this? No stir.
No stir.
Stands for neuropathy, optic obstruction, think retinal vessel occlusions, severe retinal disease, trauma, inflammation, like optic neuritis, and rare tumors.
No stir. Neuropathy, obstruction, severe retinal trauma, inflammation, rare tumors. I like it. Catchy.
Hopefully memorable. Another key thing, always link RAPD to the afferent pathway, the input pathway. And remember, the problem is before the optic chiasm crossover.
Afferent, before the chiasm. Got it. What about how this might look in an exam question? Could you give us a quick example?
Sure. Imagine this. A patient comes in, sudden blurry vision in their left eye, and it hurts when they move the eye. You do the swinging flashlight test. When light moves from right eye to left, both pupils seem to widen slightly. What's the key finding?
That sounds like a left RAPD, suggesting maybe optic neuritis.
Exactly.
Yeah.
That's the kind of clinical picture. Or another one. Patient, long history, poorly controlled glaucoma, much worse in the right eye. What might you find on pupillary exam?
You might expect an RAPD in that worse right eye. Less constriction when you shine the light there.
Precisely. And one final tip. Always connect the management back to the cause. If you figure out the why behind the RAPD, the what to do about it becomes much clearer.
Those examples are great. Really helps picture it. Okay, so let's quickly wrap up the key takeaways for RAPD. It's that unequal pupil response, signaling an issue in the afferent visual pathway, usually optic nerve or severe retinal disease.
Yep.
Swinging flashlight test is how you spot it.
Crucial.
And management is all about finding and treating the underlying cause. Spotting this sign is potentially a really early catch for serious stuff.
You've got it. And hopefully this deep dive has given everyone listening a really useful, high-yield overview for their MSRA prep.
Absolutely. You know, it really is fascinating how just watching the pupils react to light can tell you so much about the hidden wiring of the visual system.
Yeah.
A good reminder to be thorough.
Couldn't agree more.
And look, if you want more top-notch resources for your MSRA revision, seriously, do check out PASMSRA.com and also FreeMSRA.com. Loads of great stuff there.
Good shout.
Thanks so much for joining us on this deep dive.